I do want to make clear that although the framework here is single payer, and I'll be explaining what single payer is and what it is not, another way to, and along with and I think the justification for this is that every other rich capitalist democracy around the world has something like it. The other way to view this is simply a critique of what our current U.S. healthcare system is, regardless of what you think the improvements down the road ought to be. So either way. I have no commercial interest. I am on the executive committee for the New York Chapter of Physicians for a National Health Program. This is an outline of the slide sets that you should have gotten, and there'll be a part 2 later on that is specifically on the prescription drug prices in the United States. So today will be number 1 through 7 of the outline that you see here. So let's talk big picture background, and I want to thank you all for being able to join me for a slightly longer than the usual 50-minute session so I can ground us here. And especially as medical students, you are of quite a different generation than I am from when I went to medical school in 1982 to 86. And so I sort of want to look at what's happened in the United States beyond just healthcare, on the social and economic changes in the context of which our healthcare system and our health status in the United States exists. And I'm sort of using the mid-1970s as a flipping point, as many folks do. So if you think yourself, what's you think maybe better since the 1960s, what's worse than the 1970s, for all the problems that we have now, we have at least legal civil rights for African Americans, legal civil rights for women in a way that we didn't have previously, legal civil rights for LGBTQ persons, and since at least 1965, better legal immigration, thanks to the massive changes with the Immigration and Nationality Act of 1965, along with Civil Rights Act, Voting Rights Act, and so forth. So many changes for the better since before the 1960s. But what's gotten worse since the 1970s is a worsening, in fact, of overall income inequality, wealth inequality, intergenerational mobility has dropped, wages and income and wealth falling behind for not just poor folks, but actually for the very, very large middle majority. In fact, basically, the middle 90%. So the top 5% and the lowest 5% are actually maybe doing better than they had in the past. But a huge number of folks in the middle, the overwhelming majority of folks in the middle, have actually had a worsening of income and wealth. Higher costs of education, you know this better than I do, student debt. Worsening situation recently for undocumented immigrants and refugees. And perhaps you can think of some other issues, perhaps around the way our democracy works in terms of things like extreme gerrymandering, packed federal courts, and things like that. So this is looking across, as I will for quite a few of these slides, across the other rich capitalist democracies. I don't say Western because this absolutely is including countries like Japan, South Korea, Taiwan, as well as all of Western Europe and North America. So this is from the OECD, and it's called the Gini coefficient. It's a simple measure of income inequality in a population. So if everybody had the exact same income, every single household, every single person, the exact same income, the Gini coefficient would be 0. And if there was complete inequality, only one person had all the money, Jeff Bezos or whomever, and everybody else had no money, that would be a complete inequality, and the Gini coefficient would be 1. And what you see here is the United States is an outlier to the right. We're not the absolute worst in this group of countries. Turkey, Mexico, Chile, and South Africa have worse income inequality, but pretty much the entire rest of the rich, more or less capitalist, more or less democracies around the world do better than us on that. Um, since the 1970s, wealth and income inequality has gotten worse. So there was a great flattening, basically, from the peak prior inequality period of the Gilded Era through the 20s, and post the Depression with FDR and the New Deal, as well as frankly, the stimulus that World War II created, but continuing because of deliberate economic and social and political policies, continuing all the way into the mid 70s, late 70s. The percentage of total wealth in the country claimed by the top 1% went down. And it continued to do that post World War II through the 50s, through the 60s, and into the 1970s, and then it started getting worse again. What we see here is one of the policies that has contributed to it. So we've had some growth, and certain sectors of the American population have claimed most of that income growth. And what you see here is for that earlier period of 1946 all the way to 1980, what you see here is that all income percentiles across all of the population, from low income, the 5th percentile, to the highest income, 95th percentile, pretty much all persons got an average annual growth of about 2% in their income. And it was pretty even across all different groups, except for the very, very wealthy, who in fact had a lower increase from their high starting point each year. Compare that to the period of 1980 through 2018, where the average annual growth is actually negative for the lowest percentiles and much lower for the middling percentiles. And it's only until you get into the top 1%, and even the top 0.01%, that their annual average growth in income has just gone off the chart, literally. So what are the reasons for this? Well, one of them is a change in tax policy. So this is looking at cumulative taxes, average tax rates by income as a percentage of that pre-tax income. And that's not just the nominal tax rate, which is to say the amount that folks are supposed to be paying, but also treating capital gains and earned interest differently in wages. So all of these changes, and the income tax changes in how we treat capital gains and earned interest, have changed. And the result of this is that whereas in 1950 in the light blue line, the working class, middle class, upper middle class all paid a lower percentage of their income, and wealthiest paid a higher percentage. That's the line, the light blue you see in 1950. As we've gone forward in time, due to deliberate changes in tax policy that, it was a choice to make. It could have been made. It didn't have to be made. What we see here is that the wealthiest folks are paying less over time. What we see here is the gap between productivity and wages. So in addition to tax policy, there's been a deliberate policy of suppressing worker wages. The federal minimum wage hasn't gone up. State minimum wages are very variable. Some of them have gone up, some haven't. There's been an increase, frankly, in wage theft relative to what the law requires. And what we see here is productivity, GDP, however you want to measure it. The productivity in the United States has continued to decline each year, as shown in the red, and wages used to climb parallel with productivity. So from 1947 until the early 70s, you see the red and the blue lines overlap. But since that same mid-70s period, real wages, adjusted for inflation and buying power and so forth, have in fact been flat, or even gone down. And if wages had kept up with productivity, there would be an increase from an adjusted 697 to 1258. So what you can see there essentially is that wages for working class people would essentially be double of what they were if wages had kept up with productivity. There's a huge gap between what the the average CEO makes and what the median worker makes. And there always has been. CEOs make more than the average worker at that firm, at that business. American polling suggests that what people think is fair would be a 7-to-1 ratio, and what people think it actually is 36-to-1. Back in the good old days of 1970, it in fact was 45-to-1. And in the United States at this time, it's now 844-to-1. People don't realize this. I think there would be a little bit even more upset if folks realized what was going on here. It's quite a stark difference. And by the way, it doesn't have to be that way. Again, looking at international comparisons across the other rich capitalist democracies around the world, what we see is that the United States is a gross outlier. The comparison uses a slightly different data set, so it's the 802-to-1 in the United States here, and you can see none of these other countries even approaches anything like that in terms of their CEO to average worker wage gap. So again, the minimum wage, if it had kept up with productivity, would now be, well, in 2016, it would have been $18.85. So you may have heard the slogan, fight for 15. Well, it really ought to be the fight for 20 if things were going to be keeping up. And what we see here again is just that the actual minimum wage just has not kept up with productivity. And even lower is the so-called tip sub-minimum wage, which is not $7.25. It's actually $2.13. So that's what you make, let's say, waitressing or farm work or other kinds of work. That basically this was set when they brought in the minimum wage back in late 20s, early 30s. One of the fights was, well, we don't want to actually pay persons of color the same amount as we do white males. And it was a deliberately sexist choice of which were the tip minimum wage. So it was domestic work, it was waitressing, that sort of thing. So basically it was jobs that were predominantly African American, Hispanic American, or women. That is the actual historical origin of the tip sub minimum wage, and it continues to this day. Again, showing that the wages for persons who are starting at a lower baseline have had actually a negative increase. Middle wage group has had a minimal increase, and the very highest wage earners, so persons that are actually working for salary, have had a greater increase. Now, association is not causation, but if I showed you this graph and didn't tell you anything about it, you might think that, gee, perhaps something is going on here, that the two lines are in essence mirror images of each other. And what this is showing is that as in the 1920s, the 1940s and 50s and into the beginning of 1960, as union membership went up, the share of the income going to the top 10% went down, and that as union membership dropped off starting in the 1960s and 70s, that the share of the income going to the top 10% starts climbing again. So there is a suggestion here, and there's other research showing that the rise in union membership goes with a rise in income and vice versa. Now, as bad as these disparities are amongst all Americans, not surprisingly, it is even worse for persons of color. This is showing, for example, median household wealth, and remembering that wealth is accumulated over multiple generations. So you might inherit a home, or at least inherit the ability to get an advanced education because of the wealth of your parents and your grandparents. So what this is showing, that white college graduate has household wealth of $391,000. By comparison, a white high school graduate is $100,000, but a Latino college graduate and a Black college graduate are lower household income than the white high school graduate. And this is just showing that accumulated history of racist disparity in the United States, of being able to accumulate wealth and pass it along. This is showing Another way to be showing it is just overall the household median wealth by group. Whites overall, 188,000, blacks 24,000. I don't think people realize the level of wealth disparity between persons of color and white Americans. So let's turn now to healthcare. One of the things I would suggest is that the other rich capitalist democracies do it better. Not perfectly. They have their own issues. But what we see here is a percentage of GDP adjusted for differences in cost of living in the comparing the United States in the, I don't know, red orange, would you call it, to basically all these other rich capitalist democracies. And what you see if you go back to the left, 1980, is that the United States is already on the higher side, but there's kind of a bit of a clustering somewhere between 5 and 8%. And what you see is that, of course, as technology is improved and there's new treatments and costs go up in general in healthcare, it seems, the other countries also have risen, perhaps from roughly an average of 6% to maybe an average of about 9% there. But the United States has been accelerating away from them. So it's not only that we were just a little bit above the average before, but now we are way above the average and accelerating away from the other countries. And again, the difference is getting worse. If this is the outcome. So if this is the amount of input that we're putting, money, going into the system, well, are we getting our bang for the buck? Well, this is life expectancy. And again, what you see here is back in 1960, the United States was middle of the pack, pretty much average life expectancy amongst these countries. And then as we've gone forward in time, the other countries have gone up in life expectancy. The United States has gone up a little bit until just the past few years when it's actually gone down. But the difference is accelerating. The U.S. curve is dropping off and away from the others over time. Now, one of the things, so this is just showing that life expectancy by amount of dollars spent. So this is literally, if you will, your bang for the buck curve. And what you see is that all the other countries, all those other rich capitalist democracies around the world, Japan, Switzerland, Germany, the UK, etc., all of them are sort of clustered in the same area. And to quote Sesame Street, one of these countries is not like the other. And what you see here is it's acceleratingly away the curve. The difference is divergence is even getting worse. Now, it's often given the excuse that, oh, well, the United States is an outlier because we have a worse history of racial disparities, which is true, and also that we have more immigrants and more diversity, and other kinds of explanations like that are often given. The problem is that doesn't explain, that might say why the United States is worse than the others. It doesn't say why this divergence is getting worse. And I would suggest that we're going to find out why the divergence between bang for the buck dollars spent for life expectancy is getting worse in the United States. Now, we have to distinguish between health and health care. There are many determinants of health, and there are determinants of healthcare outcome where health care makes a difference in outcome versus other things that create a worse baseline, and also where healthcare maybe doesn't make a difference. So there's a standardized set of causes of death that are referred to as avoidable deaths. Deaths where healthcare intervention can make a difference, and so-called avoidable mortality. And what we see here in the lighter peach, if you will, is back in 2009, the United States had the highest deaths per 100,000 just within those avoidable mortalities across these countries. And then 10 years later in 2019, as showed in the, call it orange rust, I'm not sure, the darker color below, what you see is, well, the United States, up through 2019 at least, did manage to improve by 5%. But every other one of these countries had a much larger decrease in that avoidable mortality rates per 100,000, such that even our slight improvement is not even at their prior baselines. And again, they are acceleratingly away from us in their ability to improve. Now, sometimes when we talk about single payer in the United States, the accusation is, well, if you do that, it's going to cause rationing. So I just wanted to point out that these other countries, in fact, are not rationing. So they may be spending a lower percentage of their GDP overall in healthcare, but in fact, they are providing more actual healthcare to people by a variety of measures. For example, this is hospital inpatient days per capita. And again, the United States is towards the bottom. Notice that our Anglophone friends, Canada and the UK, are also towards the bottom. We'll come back to that. The United States, I would suggest, is the worst of these countries. And for very different reasons, Canada and the UK are number 2 and number 3 worst. But for very different reasons from each other and from the US. What we see here is outpatient. So what you see here on the left slide is average outpatient ambulatory care visits per capita. And again, the United States is towards the bottom and way below the average. We also have the lowest number of practicing physicians per thousand population. And one of the big debates in the United States is, should we have more medical students, and or should we expand what nurse practitioners and physician assistants and those folks can do? Physicians are usually opposed to practice expansion like that, but we are at the bottom in terms of providers per thousand population. So that may be a problem to address as well if you're actually interested in rationing. Again, it's the United States, in fact, that rations. We ration by the ability to pay rather than by healthcare need. This is showing that U.S. patients skip care more often due to cost, and even the higher income group in the United States, this is quintile, so the highest 20% is actually skipping care more than the lowest 20% in other countries. So again, what you see here is that 50% of the lowest 20% folks on the far right in the United States report skipping care. And again, this is, done by methodologies that were the same across all the countries. But even amongst the highest 20%, 27% of persons report skipping care, which is essentially higher than all the other countries except tied for New Zealand, as shown here. So there really are cost-related access problems to medical care in the United States that dwarf what's going on in other countries, and that is rationing. There's this composite healthcare system performance that's done every couple of years with the OECD in collaboration with the Commonwealth Fund. And again, what you're seeing here basically is we are an outlier. One of these countries is not like the other. It's us, the United States, is an outlier compared to all these other rich capitalist democracies around the world. Well, this adds up to some really bad outcomes. Numerous studies using different methodologies in the United States, as shown on the left, have shown an excess number of deaths per year in the United States due to persons in the United States either being uninsured or underinsured. We'll come back to that term underinsured shortly. My fellow advocates often point to the 68,000 excess deaths per year, 28% higher mortality rates than the other countries. That 28% higher mortality rate than would be the case if everybody had more comprehensive insurance. I actually like to point to the low number. The low number was done by a conservative group explicitly to debunk the high number. And so the self-declared, they were honest about it, debunking study showed that we only have a 6% higher mortality rate and we only have 18,000 excess deaths per year. So, wrong. Again, if you count up all of those excess deaths in the United States compared to these other countries, we essentially have accumulated 500,000 missing persons. Again, the references for all of this are in the links at the bottom. So let's talk about Americans now, persons living in America. I would suggest that there is a continued problem of uninsurance, but actually, the even bigger problem is underinsurance, where even if you nominally have health insurance, it's too hard to get health care, it's too expensive, it's too complicated, and one of the driving parts of this is it's too for profit. So, uninsured, completely uninsured persons. Let me just say here that the ACA did make a real difference. Most of that difference was the expansion of Medicaid. So in the United States, the default way people get health insurance is through a group plan, buying private health insurance, and their group is usually their employer. So if you have a good healthcare benefit, which perhaps say Montefiore employees have, my wife was one, your professors are another. So they will Montefiore will pay some part of the premium, and you as the individual will pay another part of the premium, and you're buying from Aetna or United or Empire or one of the other for-profit insurance companies. That's the default method. What if you don't belong to a group that allows you to purchase health insurance? Well, prior to the ACA, you were kind of out of luck. Buying insurance as an individual was super duper expensive. So one of the changes the ACA made is it said, well, you live in New York State. Therefore, if you have no other group available to you, you can buy off the New York State Exchange, and your group is, I'm a resident of New York State. But what you were buying off the exchange was still Aetna or United or some other for-profit corporate insurance plan. But at least you were buying at a group rate, not an individual rate. And depending on your income, there might be some subsidies, which meant taxpayer money going to pay the premium to Aetna in order for you to buy it. So again, a public subsidy to the private for-profit entity for a fragmented, broken system. The other thing the ACA did is expanded availability in Medicaid in multiple ways. One of the ways it did that was principally Medicaid was available to folks if they were not only poor, but also had a child dependent. So if you were a single adult and poor, in most states you couldn't get Medicaid. The other is it raised the threshold, so raised who was eligible, and it also raised the threshold of the poverty level at which you could get it. So it made a real difference. It basically cut the uninsured in half. So before we had about 52 million uninsured, 55 million, there's different ways to measure it, but roughly it cut it from the 50s to 25 to 30 billion. So who are the remaining uninsured? There is a myth that the majority of the remaining uninsured are undocumented immigrants. Nationwide, that is false. Now, I will say New York State is different, but nationally, the overwhelming majority of persons who remain uninsured are in fact U.S. citizens, eligible for either Medicaid but not enrolled because of the complexity of the system, as shown in the dark blue on the right, eligible for subsidies but not enrolled because of the complexity of the system, the paperwork as shown on the 25% top right. About 15% are ineligible subsidies because their income is just above that, but they still feel like they can't afford the premiums. Ineligible for subsidies because they have an offer of employer health coverage, but they haven't actually bought it because it's too damn expensive. Ineligible to assistance due to immigration status. The mythical majority is in fact 16%, and an additional 9% are ineligible because their state didn't expand Medicaid. The greater problem is underinsurance. Too expensive, doesn't cover you when you're sick. You still have too high out-of-pocket expenses, and just too hard to get into the system and find care. What this is showing is the increase in premiums and increase in deductibles over time. So these are folks who have insurance through their own workforce, the default standard in the United States, through their employer. The light red at the bottom shows the overall inflation rate. Workers' earnings are shown in the dark blue, so increasing over this period of time by 26%. And what you see here is that the family premium has been accelerating at twice, at double the background inflation rate and double the workers' earnings rate. And then once you've bought insurance, the deductible, how much you have to pay out of pocket before the insurance even begins to pay, has tripled over that amount of time. And so we refer to this as high deductible insurance or possibly junk insurance. Now, there's another problem. If you've bought insurance or have insurance through Medicaid, you're nominally insured, but does every doctor take you? Does every hospital take you? No, there's limited networks based on which insurance you have and what the providers take. The most limited network is Medicaid. Only about 25% of physicians nationwide take Medicaid. May have actually dropped recently. And I am proud as a general pediatrician to say that about 70% of general pediatricians do take Medicaid. However, if we need to refer somebody to a pediatric specialist, even in peds, the ped specialists mostly don't take Medicaid. And so what this is showing is the percentage of pediatric subspecialists in the dark blue that do take private insurance, but in the light blue that don't take Medicaid. And so again, if, only half the doctors or half the hospitals take your insurance, you nominally have insurance, but you may not have access to care. Another problem is this increase in copays and deductibles. There was a big push to argue that patients have to have skin in the game, was the term, or a moral hazard. Otherwise, there'll be people accessing excess health care that they don't really need. I don't know about you, but I'm not going for the extra colonoscopies just because they're free. But we in fact have actual research evidence of what happens. So this was showing what happened when people transferred from a low deductible health plan to a high deductible health plan, and what happened if they had non-specific chest pain, which is to say a chance for a heart attack, and these are over 65s. So what we see here is when they switched from the low deductible to the high deductible plan, money was saved for the insurance companies. This was emergency room visits went down, hospitalizations went down. This is the kind of thing that happens under so-called Medicare Advantage rather than true public Medicare, where it's been privatized to a private insurance company. So ER visits go down, hospitalizations go down, cost of non-invasive testing goes down. Unfortunately, the rate of heart attacks goes way up. So 30 days out, when they switched to a high deductible plan, money was saved with less ER visits, less hospitalizations, and less testings, but the outcome was more heart attacks. This is showing what happened when there was a change in the copay for a drug. So you have a prescription, you go to the pharmacist, you give the pharmacist the prescription, and then they come back to you and say, well, insurance is only covering so much, you have to cover this much more. And so a change of just $10.40 on average, a 34% increase from what it had been in this, essentially a crossover group, was showing that the total number of prescriptions went down 22% for things like statins, ACE inhibitors, inhalers for asthma, oral diabetic agents. The chance that people were fulfilling the prescription all went down. And lo and behold, mortality went up. Numerous other examples in the literature, and these are all cited in the links below. And again, patient skin in the game, in fact, kills. The whole concept that healthcare spending needs to be controlled by limiting access to care for persons who are sick simply doesn't pass any data test. It seems obvious, you don't want all of those people wandering into offices fetching that they're sick and using up healthcare. But in fact, that's cheap. That kind of excess usage, doesn't really cost anything. If you look at where the percentage of healthcare spending on the right, what you see is, in fact, that over 80% of U.S. healthcare spending is only among 20% of people. And in fact, you can go up and it's only 5% of people that account for half the healthcare spending. What's going on here? Well, in fact, it's a relatively smaller number of people who have serious, real, non-voluntary care that account for the large majority of spending. And if you add the moral hazard of the copays and the deductibles and the out-of-pocket costs, you're not going to reduce significantly the system-wide cost. What you do is you delay care, you prevent necessary care, and you get more deaths and more bad outcomes. In the United States, we have something called medical bankruptcy that basically doesn't exist in the other rich capitalist democracies around the world. 2 out of 3 persons filing for personal bankruptcy attribute to healthcare costs as a major factor. Either the medical bills put them into bankruptcy in terms of how much they were being charged out of pocket, or they got sick, and because we have employer-based health insurance, when they got sick, they lost their job, which meant they lost their insurance. And of those folks going medically bankrupt, over 3/4 of them had health insurance when they became sick. So the whole idea that, so many people in the United States have health insurance, it isn't a problem, is simply false. And this is what we mean by the underinsurance problem. During the Great Recession, which was identified as mostly around mortgage failures, home foreclosures, in fact, medical debt was the majority reason for why people were suddenly unable to pay their mortgages. It's the most common reason for collection calls. It's the most common reason dings on credit reports. It's the most common reason for personal GoFundMes. So in summary, having private health insurance in the United States is kind of like having a hospital gown. The chances are your behind isn't covered. And again, why? Copays, deductibles, all of those out-of-pocket costs, despite having insurance. This trade-off of if you pay a higher premium, you'll have less out-of-pocket costs when you do get sick. But if you can't afford a higher premium, you go with a low premium plan, betting that you won't actually need to use the insurance when you do get sick because it's going to be too expensive. And again, nominally have insurance, but still go bankrupt. If you actually get sick and the limited networks, you nominally have insurance, but you still can't actually access care. There was actually quite a nice little natural experiment with our brothers and sisters to the north in Canada. So in Canada, they fully implemented, it went province by province, starting in Saskatoon. But over a few years, they fully implemented what they call Medicare. So their province-based, federally supported health insurance for all persons living in Canada. So that passed hit in 1972-73 period. At the same time, the United States did something else in red. We passed something called the HMO Act. This is when there was a massive expansion in for-profit healthcare. This is when the investor-owned for-profit hospitals and clinics started opening up. They were not legal before then. Again, that's a political choice. It is not inherent that you allow investor-owned healthcare. It's also when a lot of the not-for-profit insurance companies like Blue Cross Blue Shield converted to being for-profit insurance companies. So people don't fully realize that Blue Cross Blue Shield is a old label that isn't what it was when it was founded. They're all for-profits now. So this is the expansion of for-profit healthcare. And what you see is that Canada over time, we were paying about the same amount. That's the what you see there to the left of 1972. We were paying about the same amount in percentage of GDP. And when each of these countries made their changes in the early 70s, after that there was a divergence, and the U.S. healthcare costs accelerated away at a much higher annual increase rate than Canada's. Well, what about bang for the buck? Well, over that same period of time, the life expectancy in the United States, which was already a gap of 1, then went to a gap of 3 years, and it's continued to climb since the end of this data point. So we're, again, having worsening outcomes and paying more for them. So what about this whole concept of for-profit? Now, if I am a private doctor in my private office, I'm making a profit. That's my income. And that's not what we are talking about here. So just to be clear, when we're talking about for-profit, there's essentially 2 different terms. One is strictly the IRS terminology. So depending on how the legal structure of the entity, you can be a for-profit or a not-for-profit. So all the hospitals in the New York State are nominally not-for-profit. They are private, voluntary, private, not-for-profit hospitals. Montefiore, Presbyterian, Mount Sinai, etc., etc. All of those are officially, in terms of tax purposes, not for profit. Now, there's another term, which is really the key one here, which is that it's third party investor owned care. So if I'm a doctor and I own it, my practice, I'm making money, but I'm not a third party. There's no third party investor. I may have taken out a loan from the bank, but there's no third party equity investor owning the business telling me what to do. And what we see here is both traditional for-profit companies and, even worse, private equity have inflated costs and inferior quality. So what's the extent of for-profit ownership? Well, amongst general hospitals, it's still pretty low in the United States. But amongst any sort of specialty hospitals, including substance use specialty, hospice, home care, skilled nursing facilities, dialysis, all of those freestanding lab or imaging places, urgent care centers, surgery centers, etc., higher and higher percentage of those are for profit. And in New York, it's been increasing as they've worked ways around the law, so that all of those urgent care clinics you see around the city are mostly for-profit entities. Where's all that money going to? Well, we, the providers, the physicians, are at the bottom. This is the providers, the physicians, nurse practitioners, PAs, anybody can bill for services. We're actually getting the least amount of the profit out of in the healthcare industry. It's mostly the pharmaceuticals, also the insurers, the pharmacy and lab benefit managers, the PBMs. And by the way, the PBMs, the insurers, and the pharmaceuticals, in many cases, are the same parent company. Let's look at compensation. So this is the total executive package. I'm not naming names for individual CEOs. This is the entire executive boardroom in terms of their pay. So when folks say there isn't enough money to do it, I'm suggesting that the money is there in the system. It's just not going to healthcare. It's going elsewhere. One of the problems we do have, and this is true for Montefiore and for the others in New York City as well, is that a lot of the nonprofit health care hospital systems, in fact, are acting as for-profits. And so if you're a not-for-profit, but you have excess revenue over expenditures at the end of the year, but you're an IRS deemed not-for-profit, what do? Well, one of the things you can do is you can build a new building. One of the other things you can do is spin off a for-profit investment fund. And that's what they're doing. So they will spin off a for-profit fund separate from their not-for-profit corporate entity. And they will go into hedge funds and private equity and the like. And this is all over the country. A lot of these not-for-profit, and here I'm going to name a few names, a lot of these not-for-profit hospital CEOs, the deans of medical centers, the presidents or CEO of medical centers, in fact, make far more money collecting as consultants for pharmaceutical companies than they make in their board pay, in their pay from the being the head of the hospital. So clear conflict of interest here. For-profit hospitals cost 19% more. So this is what used to be, say, Hospital Corporation of America. They're always changing their names. Again, we don't have this sort of hospital in New York State that I'm referring to here. These are Wall Street, publicly stock traded hospitals, but they cost more. They have higher administrative overhead costs. And of course, Canada is lower than even the best in the United States, and we'll come back to that. And they deliver more low value or no value care. So again, the major medical teaching centers like Montefiore and the general primary care not-for-profit hospitals, standalones, have less overuse, and the for-profits and the large multi-system not-for-profits outside of the medical center, teaching centers, have more low value care. They go out of their way to avoid anything that's unprofitable, so they adjust their case mix and who they admit only to more profitable kinds of care. They have the highest readmission rate for every condition. So this is a standard measure of bad care if a patient is readmitted within a certain period of time. And again, the not-for-profit hospitals, the public hospitals do better, and the for-profit hospitals do worse on readmission rates for pretty much every serious condition. For-profit dialysis centers have higher death rates. 7% higher amounts to 3,800 excess deaths annually. One of the reasons dialysis centers, for-profit dialysis centers, have higher death rates is they don't like to discharge patients into a kidney transplant. They make money on dialysis, and they actually, it's been shown, are more resistant to transferring patients to getting a kidney transplant that they could get, because then they lose that person for dialysis. And this is showing it for kids, as a pediatrician. Transplants is lost customers. And again, the likelihood, this was looking at, I think it's odds ratios, not risk ratios, or likelihood ratios of for-profit dialysis clinics versus not-for-profit, getting waitlisted, less likely to be waitlisted, less likely to be transplanted, less likely to receive a deceased donor transplant. So what about private equity, and what is private equity? So we used to just have the sort of Wall Street publicly traded for-profits, and the problem there was inherently that their fiduciary responsibility was to make money. And if they're publicly traded on Wall Street, what they need to do is basically increase their earnings every quarter of a year, quarter on quarter increase in earnings, in order to keep their stock price up, and they're increasing in their stock valuation. Even if they make money, if it's flat, they get penalized on Wall Street. That's the problem with the publicly traded companies. Private equity is a whole other game. So I'll come back to what private equity is in a moment, but what you can see here is the massive increase in private equity investments in healthcare over the last 20 years. So what is the difference between private equity and for-profit corporations? Well, there's basically no regulation. It's all secret black box. They have a very short time frame. They basically are telling their investors, we're going to beat Wall Street over the next 3 to 5 years if you give us your money. And then you will get your money within 3 to 5 years, beating Wall Street, and we're out. And we're going to do that in capital gains, which are taxed less than at corporate income rates. So private equity's really been taking over every single part of the healthcare system. And again, they guarantee, or they promise their investors, the reason people put money into them as opposed to Wall Street is short-term, larger increase in wealth, in what they do back. Now, how do they do it? Well, they buy with debt, then they cut staffing, cut supplies, cut services, reduce access, sell assets, so they may sell the hospital because it's more valuable as real estate to then make new housing or a shopping mall, or maybe not a shopping mall anymore, but new housing. Basically, new luxury housing is what's happened, at least in New York, with a lot of the hospitals that have closed. They sell the assets, they can use their monopoly power to charge higher rates, and they do a lot of self-dealing. So what do I mean by the self-dealing? Well, let's say you're a for-profit clinic or hospital, and you need janitorial services. And so you will have a contract with a cleaning company. Well, lo and behold, the private equity company also owns the cleaning company as well as the hospital and clinic. So the money that they are paying ostensibly for a necessary service is still going back to the same group. They'll often continue to load up in debt and eventually go bankrupt. Well, if they go bankrupt, how do they make money? Well, between the initial purchase and the going bankrupt or the selling to somebody else, they're paying dividends to those primary investors. And they may be paying dividends with debt. Yeah, that's legal. Basically, they've been profitable at every step along the way for the primary investors because they've been paying dividends, so that even when eventually it goes bankrupt or is sold for parts or is sold to a public company, which is what happened with One Medical that started this way and then got sold to Amazon, they have been skimming off through dividends. Now, I don't have time to go into all of the examples. There's hundreds of examples, and this link will send you to both reports and peer review medical journal articles on all of this. So what's going on here? So essentially, you've taken your nicely constructed, beautiful Lego house, and you've paid it for debt, reduced costs, break it up, and selling it for parts. And unlike the publicly traded companies, this is really just playing financialization games. There's no increase in productivity. There's no long-term plan for staying in business. And it's not about healthcare services. Private equity nursing homes have had a higher mortality rate, higher use of antipsychotic medications to basically numb their patients, knock their patients out. They actually cost more in their Medicaid billing, and parallel to that increasing the psychotic prescriptions to knock people out, they reduce their staffing. Private equity hospital takeovers, same thing, less staff per bed, and increasing profits. So again, we've had 40 years of free market reform, essentially since that HMO Act. The solution to healthcare getting more and more expensive that they have been saying is let's make it more difficult to get. So they've added more middlemen, whether that's managed care, pharmacy benefit managers, Medicaid disadvantage, raising the unit costs of all the items, the drugs, the equipment, the supplies, the labs, and then the for-profit diverting or extracting more dollars and a higher percentage going to profit, not to care. Again, limited networks, copays, deductibles, this restriction of coverage, prior authorizations as a way to delay or block care, monopoly power, where the insurance company, the pharmacy benefit manager, and the retail pharmacy are all the same company. And now they're going to primary care, so they can go into primary care, salary the doctor, prescribe the medicine, go through the PBM, go through the pharmacy, and the insurer, and it's all the same company. You can imagine the bookkeeping games to be played. And as we've seen, this causes harm to patients, but it also causes harm to doctors. And if you talk to your older clinical professors, they will tell you that, life's just gotten more and more aggravating to practice medicine. Sorry, I don't mean to scare everyone off. So the result is actually that Americans, in fact, use less healthcare than other industrial, rich, and capitalist democracies around the world. We're the ones rationing. We have worse healthcare outcomes, and we're spending twice as much. So it is truly an American exceptionalism. And I love this George Carlin quote, the comedian, that I don't believe that there's any problem in this country, no matter how tough it is, that Americans, when we roll up our sleeves, can't completely ignore. And I can't help but think of gun control and climate change as well as healthcare. So why do we think Medicare for All would help, or expanded and improved Medicare for help? Well, this is looking at age group specific mortality rates. Age group specific mortality rates among 17 peer countries. So you can see here for men and women in red and teal that the United States is at the bottom. We're essentially 16th or 17th across all these 5-year age group in mortality, age group specific mortality rates, until something happens at age 65. All of a sudden, at age 65, the U.S. does a lot better. All of a sudden, there's almost universal coverage, nominal coverage with Medicare. The out-of-pocket costs are way down with Medicare compared to private insurance. And all of a sudden, the age group specific mortality rates, we start doing a lot better. And in fact, in the oldest group, we're finally number one, but only if you're in your 90s. So what is single payer and how does it save money while covering everybody? So let's say you're not buying into this single payer stuff. Fine, no problem. Can we agree that there should be universal coverage, that everybody, that healthcare at some level is a human right, that everybody in the United States, a rich capitalist democracy, everyone ought to have healthcare, access to healthcare? Do we agree that it ought to be simple? That you don't have all these paperwork barriers, you don't keep changing what your eligibilities are, this churn of on one insurance, off another insurance, and the focus could be on healthcare, not billing. And by the way, that's good for the doctors too. It's also good for the doctors if everybody who walks in your door has coverage. And is it affordable? However you're going to pay for it, whenever you're paying for it, that people can afford it, including middle-class people, working-class people, poor people. So you may notice these add up to U.S.A. So we would like our healthcare to be U.S.A., universal, simple, and affordable. And if you can come up with another system to achieve these things, then please let us know. So why do folks not support it already? Well, fear of the unknown, fear of change, fear of loss of personal income and institutional revenue in the case of the hospitals, and some degree of faith in the private sector, which is related to sort of a knee-jerk U.S.A. is always number one. And what I would suggest is let's look at some facts and evidence rather than fear and faith. Again, let's take a moment and go back to very first principles. What is the point of insurance? Any insurance, not just health insurance. What is an insurance pool supposed to be? The point of insurance is to spread the risk. We have insurance for events that are relatively rare. They don't happen every single day. And where when the event occurs, it's too expensive for any one person to pay for. So whether it's auto car insurance, if you get in a wreck, or homeowners insurance if there's a fire, or health insurance if you have a heart attack, or get cancer, or run over by a car, or get burned up in a fire, you need health insurance. So the way it works is by pooling. If everybody is paying a little bit of money in all the time, then at any given point in time, there's enough money to pay for those individuals who have that event. So that's the point of risk pooling, which is the whole point of insurance. And the most natural and efficient risk pool is to just have everybody. And that's why the mantra of everybody in, nobody out isn't just a slogan. It's actually an economic requirement for how an insurance pool is supposed to work. Now let's look at for-profit corporate health insurance. What is their goal? Is their goal to cover everybody? No. Their legal fiduciary responsibility is to make money. And the way they do that is creating an investment pool for Wall Street. So the money you're putting in isn't money to be an insurance pool for healthcare. It's actually meant to be an investment pool on Wall Street. Healthcare, actually providing healthcare, is in effect in supermarket terms what you might call the loss leader. They actually refer to it as medical loss ratio. Now, how do they make money? Well, they make money in a couple of ways. One is they cherry pick. So instead of having everybody in the United States in, they actively try and select for persons who are more healthy or more wealthy. And they lemon drop. So when people get sick, and we see this with the Medicare Advantage plans, when people get sick, they try to dump people back into the publicly covered pool. So we have what we call advantageous selection, selecting for the healthy and wealthy, and adverse selection, dumping the sicker, poorer people into the public system or into no system. Now, another thing we know about healthcare economics is it doesn't follow simplistic supply and demand. We've known this since the early 1960s. There was an economist who won a Nobel Prize, Ken Arrow. But basically, supply and demand assumes that the consumer can negotiate the price with the seller. Well, who's the consumer and who's the seller in healthcare? It's in fact a three-way dance between the patients who have neither the information nor the ability to negotiate, the doctors who actually generate demand for care, you're sick, you need this treatment, and the payers, I'm going to pay for that treatment. So you've got a three-way dance that doesn't follow supply and demand, where doctors and hospitals are essentially driving the demand, payers are slowing the demand, and the patients are caught in between. So what is single payer? And I'm going to use some buzzwords here about security and freedom, because I would suggest that single payer actually increases our security and increases our freedom, which I heard are good things. So it's publicly delivered, publicly funded, privately delivered. It's universal health insurance. The change is in the financing, not the delivery. Private doctors, private hospitals like Montefiore still exist. We would argue we should get rid of all of the third-party investor-owned for-profits, but they don't all have to be public entities, and they're not employees of the government. That's like the UK system with the National Health Service. That's not what this is about. progressively funded, so we have a progressive tax replacing what amounts to the flat tax of premiums, co-pays, deductibles, and the like. The mix that we have now is the same as it would be. It's not just Medicare as is expanded to age 0, but it's an expanded, improved benefit package. So all medical, dental, mental, hearing, vision, drugs, devices, long-term care. And that long-term care is really important with an older population, and the fact that there is essentially no systematic long-term care in this country. People have to either go into bankruptcy when they weren't bankrupt to get into poverty, to get Medicaid, or burdening their children or what have you. It also forces folks into nursing homes when they don't need to be. No point of service costs. That whole business about co-pays and deductibles that you have to give the pharmacist $20 before you get your drug, or you have to pay the doctor $100 up front before they'll see you. No, we get rid of those. So what does this mean? I would suggest it's the best of capitalism in the sense that it's freedom of choice for the patients. If all the patients have the same coverage, all the doctors and hospitals and other healthcare providers and the pharmacies all take it. Now we, the healthcare providers, are competing, yay capitalism, we are competing for the patients on an even playing field. So we who provide the best care, however you want to define that, will attract the patients to keep us busy and keep our incomes up. It's security for the patients because you always have it. You own it forever, regardless of changes in employment, changes in life circumstances, etc. So again, the economic incentives for what we have now with this multi-payer, fragmented for-profit insurance companies inherently perverse. We saw that before with the adverse selection problems, the lemon dropping, cherry picking. Even for the hospitals, they cherry pick by trying to get patients whose conditions require things which they can get reimbursed at higher rates for, and they try to avoid those that don't, the so-called case mix. And in fact, we have numerous studies that show that it's a net boost to the economy with more jobs, more activity. Any business that's a current contributor to the system also saves money. About 92% of persons save money. And it's also a moral argument that access to healthcare should not be treated as the widget du jour commodity. It's a social and communal good. We have numerous studies that show it actually saves money, on average 5.7% less spending, even while it's providing full coverage that's more comprehensive coverage, including long-term care that nothing is covering, including drugs, no co-pays, etc. Net boost in workers' earnings, increased longevity and labor productivity. This is the Congressional Budget Office in 2020 and 22. Numerous other studies, all listed here. Now, how do we do that? How do we cover more people with more comprehensive services, no out-of-pocket costs, no point of service costs, actually save money on that? How do we do that? Well, let's look at how much we spend to administer the insurance system. So this is just how much we are spending to pay for the Aetnas, the Uniteds, mixed in with the Medicares and Medicaids, but mostly the private insurance companies. How much is it cost to run the insurance system? And what we see here is it's on average about 5 times the cost as it is in these other peer countries, if you will. So the administrative overhead to run the insurance scheme is about 5 times. This is dollars per capita. Medicare as is more efficient than commercial insurance. So again, what we see here is the growth in per enrollee spending, and the costs of commercial health insurance are more than twice the increase of the cost in Medicare over time. What we see here is the administrative overhead of Medicare compared to some specific major companies. Aetna and United are the biggest ones going. And again, Medicare administrative overhead is lean and mean at 2%, and with all of the marketing and for-profiting and paperwork. The private insurance companies have 15, 18%. Okay, so that's the cost for running your insurance company. What about on the provider side? How much extra is it costing doctors and hospitals to deal with all of that billing through a fragmented for-profit insurance companies that, they're turning back every time you submit a bill. The first time they reject it, you have to get prior authorizations. The first time they reject it, you have to resubmit, et cetera, et cetera, et cetera. They have 20 different forms because it's 20 different companies. You have to sign up to be enrolled. That takes additional time. They disenroll you, yada, yada, yada. Well, compared to Canada, again, it's roughly 5 times. So for physician expenses related to billing, American physicians are paying, this is ambulatory care practices, are paying about 5 times what Canada pays. And on the hospital side, it's similarly 5, maybe 6 times the cost for hospitals billing their cost to bill the system compared to Canada. This kind of shows you why. So this is a comparison of Duke Medical Center. I'm not picking on Duke Medical Center. It's just that that's the one that was published in JAMA. There's no reason to think they're better or worse than anybody else in the United States, particularly. And compared to Toronto University Health Network. This is the academic University Medical Center in Toronto. Duke Medical Center consists of 3 hospitals. Toronto University Health Network consists of 5 hospitals, including 3 big ones and 2 small ones, essentially. One that's the giant, academic university medical center that you're seeing here. So 957 beds across Duke Medical Center with 1,600 billing clerks. That's more billing clerks than beds. 1,272 beds across Toronto University Health Network, 7 billing clerks. At the main hospital, they have 3 billing clerks, and at the other 4, they have 1 each. At the main hospital, it's essentially 1 billing clerk for Ontario, 1 billing clerk for the rest of Canada, and 1 billing clerk for the rest of the world. It's an academic medical center. I have known patients from New York and Boston that have gone to Toronto to get their super high-powered specialty research care. Take that in for a moment and realize we can do better. It doesn't have to be this way. This shows the growth in healthcare managers. Again, that period, especially since the early 70s, when we went with more and more private for-profit care, more and more so-called managed care, pay for performance is this week's slogan, et cetera, et cetera. And what you see here is over the 50 years, we've doubled the number of physicians. And over the same 50 years, we've gone to 40 times the number of healthcare administrators managing those physicians. So huge increase in administration and management jobs rather than in clinical jobs. What about drug prices? Well, the U.S. pays more for drugs. We'll have a later talk that is specifically on drugs. But the short answer is we pay 1.5 to 12 times the average price of the other rich capitalist democracies around the world. And they're all the same drugs. These are all multinational, transnational companies selling the same drugs. What's the difference? In every other country, they negotiate the prices. And in the United States, thanks to lobbying and whatnot and misinformation, we're not allowed to negotiate the prices. So this is showing the year-on-year inflation rate in general inflation rate in the yellow, and the brand name drug increases is the top 260 top prescribed drug products, and you see the annual inflation rate for each. And of course, as that annual inflation rate becomes cumulative, 1 year on top of the other year's increase, what we see here is an over 300% increase in brand name drugs and an over 700% increase in so-called generics. We're often told, oh, but if you don't give the drug companies all this money, they're not going to be able to do research. Well, let's remember a few things. First of all, primary science research that leads to pharmaceuticals is publicly funded. That's the NIH. Folks who won the Nobel Prize for the mRNA vaccine, were all funded by NIH, and then eventually it winds up being patented by Pfizer and Moderna. Actual research and development, according to their own data, and research and development, as you might imagine, is a pretty broad catch-all potential term there, is only 13% of drug companies' actual cost structure. They're not heavily involved in research. We'll go more into this in the Bayh-Dole Act in the drug price talk. Pharma has a higher return on revenue than the Fortune 500. I don't want to put the drug companies out of business. I love my statin. Thank you very much for my statin. I love my blood pressure medicine. Thank you very much for my blood pressure medicine. I just want us to pay the same profit-making price that France and Canada and Germany and Japan and et cetera, all pay. And what we see here is it's good to be a drug company. Their return on investment compared to the rest of the Fortune 500 is a pretty good multiple. Looks like maybe on average about double return on investment, sometimes triple in any given year. So we don't want to put them out of business. We just want them to have the same fair profit as the rest of the Fortune 500. Right now, essentially, we are subsidizing an excess profit by the drug companies compared to the normal profits that they make everywhere else. If you negotiate, if the buyer can negotiate the price, if the buyer has a monopoly, it's referred to as monopsony. But wait, it gets worse. So we'll talk about this more, but basically, we originally were sold on the idea of pharmacy benefit managers as a middleman between the insurance company and the drug company that would help negotiate lower prices rather than, God forbid, actually having the government do that nationwide. We would bring in multiple for-profit middlemen to do it. Exactly how that's supposed to work, I don't quite conceive of how somehow bringing in a additional for-profit administrative layer stuck in between, how that's ever supposed to reduce cost or efficiency. But now it's a complete fraud because they're all the same company. So it's no longer a middleman negotiating prices. It's now Aetna, the insurance company, is also CVS, the retail and wholesale pharmacy, which is also CVS Caremark, the pharmacy benefit manager. United also is the insurance company that has a pharmacy and a PBM, Humana, Cigna, etc. So it's just a complete fraud and self-dealing. So when you add all of this up, how does it work? So this is showing what the single payer numbers would look like from the center right, I would argue, Rand Corporation, independent analysis of the New York Health Act a few years ago. And what they show, and you can, get the reference, the full report if you want. The reduced insurance administrative costs, 6.5%, reduced hospital and physician administrative overhead, 5.2%, reduced cost of drugs, 6%. There's some additional costs because now we're covering everybody. There's some additional costs because we're actually increasing provider fees. That means the doctors are actually going to make a little bit more, except for the super, super highest income subspecialists. Oh, and we're also covering long-term care. And between the two, and not even taking into account the added stimulus to the economy, they estimate about 180,000 net new jobs are generated in New York State. Net savings of 3.6%. So one of the key points, progressively paid for. So higher income people who have more disposable income pay a higher marginal percentage on that higher income, not on the first 50,000 or the next 50,000. The higher amount is only on that, the higher percentage is only on that higher amount. So when people say, well, what about, are you willing to pay higher taxes? The question really should be, are you rather paying $3 now in the taxes you're already paying, plus premiums, plus out-of-pocket costs? Would you rather pay $2? And again, what this shows is how roughly in this particular estimate, based, on some specific tax assumptions, for single payer nationally back in 2013. I've got some updated numbers later, but this graph shows you the basic point that roughly the top 5% or so of persons and households would pay more, and they have more disposable income, so that's fair. That's what progressive taxation means. And the lower 95%, what a weird term, actually would have an increase in their take-home pay in effect. So it would actually be a net increase in income for about 95% of persons. By the way, lower levels of government save money. So if it's national health insurance, then states and counties save money. If it's the New York Health Act, then New York City and all the other cities and counties save money. One reason is in New York, the counties pay a Medicaid share to New York State for the Medicaid, but also governments are employers, and as an employer, they are paying for their employees and current employees and the retirees' healthcare benefits, and those would go down. And then, of course, there are savings for any charity or public hospital care that is not currently being paid in full at full rates, but then are now going to be reimbursed going forward. And what you see here is massive savings, according to the City of Albany treasurer, in what the healthcare costs would be for the government that they are the treasurer for, if the New York Health Act were to pass. So the big lie is that it's too expensive, and the big truth is that there's really cost savings as well as cost shifting, and that's the key point. So it's a reduction in the total systems costs. It's a reduced cost, depending on whether it's state or federal, and exactly how you work the taxes. Between 90 and 98% of individuals, families, and households would pay less, which means it's in effect a net increase in their income. There's lower costs of businesses for any that are currently contributing to the system. Remember, most large businesses certainly are paying part of the premium as part of their benefits package to an employee. The employee is foregoing some actual income and salary for that, but it's paying for the premium. So if they're a business that's currently contributing, like I just mentioned, and not freeloading, on average, they would save $9,000 per employee. So yes, they're going to pay the taxes for the single payer plan, but they're going to not pay the premium to Aetna or United instead. 9,000 savings per employee means they can either have more profits or more employees, and that makes for a stimulus in the economy. As I said before, lower costs for all levels, lower levels of government, creates jobs. There's a net stimulus. The Congressional Budget Office has agreed that this would occur at the national level, even more so. New York Health Act, a net of 180,000 jobs. And frankly, it just provides the security that it's always there. So, what about us physicians? Well, us physicians, or physicians to be, by the time you graduate and finish your residencies and go out there, the odds are it's going to be very, very difficult to open up your own private practice or even as a group practice amongst just owned by doctors. There has been a massive change just in a few years. COVID accelerated a change that was already occurring, whereby the overwhelming majority, 74% of physicians, are now employees of hospitals or for-profit corporate entities. Marcus Welby, look up the reference, Marcus Welby is long dead. U.S. physicians currently, under the current system, have the lowest personal job satisfaction compared to physicians in other countries. This is primary care physicians. U.S. physicians, again, primary care physicians, rate their own healthcare system the lowest compared to other physicians around the world. U.S. physicians spend less time with patients. Now, the methodologies on these two studies are not 100% comparable. It is both outpatient ambulatory care. But what we see here is roughly 26% of time with patients in the United States and over 50% of time in direct patient care in Canada. And here's another reason why. I am sure you've spoken with your clinical faculty and you've heard everyone complaining about how much time they spent on their medical records. Epic, which is widely used, I believe it's the one at Montefiore, is the most widely used electronic health, so-called electronic health record in the United States, and it's also used in other countries, by the way. So let's take a look at how many keystrokes, how much time you have to spend typing to complete an ambulatory care note. So this is the distribution curve for the average number of keystrokes, characters per ambulatory care note to close a note in the United States amongst a sample of ambulatory care practices, and used in 13 organizations in other countries around the world. And this is the average number of keystrokes in those other practices in other countries, using ostensibly the same software. So what's the difference? A lot less time. Well, turns out 3/4 of our charting is actually not for a health record. It's for a billing and insurance record. It is not for clinical work. And that's the difference using Epic in other countries and using Epic here. There's about 4 other studies since that one showing the same thing. I haven't had a chance to put in all the new slides. Not that I need more new slides. American Canadian physicians make equivalent amount of money. It's a high income in Canada. It's a high income compared to average in the United States. There are some specialties where they even earn more. Ophthalmology does better in Canada. Dermatology does less. And notice the primary care specialties generally do more. Family medicine, internal medicine, pediatrics, all doing better. OBGYN doing better in Canada. We spend a lot of time and money managing insurance companies. Again, the annual average cost for an outpatient private practice in Ontario compared to the United States, they're spending less money interacting with insurance companies. They're spending less money on administrative overhead for their practice, which means they get to keep more of their income. And in fact, American physicians are moving to Canada, not the other way around. Now, this is one of the issues that Canada has that I mentioned, making it amongst the reasons the second worst. They've actually frozen the number of medical school seats in most of the provinces with conservative governments, and so they actually have a bit of a shortage. It's easier to get into medical school for a Canadian to apply to the United States than it is for them to get into medical school in Canada. So they have, if you will, a demand issue. So just as the United States, with our aggravating, how it's so aggravating now in the United States to practice medicine, is driving people to Canada, so too is a physician shortage in many areas, sucking people to Canada, if you will. And what we're seeing is a net migration back to Canada, even of amongst Canadian physicians who moved here. So what about total payments? So in fact, 3 groups that are opposed to single payer in their own analyses all agree that more payments would go to physicians under single payer than under the current system. This is from the Mercatus Institute, which is a far-right think tank funded by the Koch brothers, the Rand Institute, a center-right organization, and the Urban Institute, a center-liberal organization, kind of affiliated in their healthcare stuff with the Clintons. Even the conservative opponents to single payer, when they do an honest analysis, wound up saying, yeah, physicians would get more payments under single payer than they would do under the current system. And in fact, physicians are changing their opinions, despite from the 1920s into the 1970s and even perhaps to the present, with sort of red scare tactics by the AMA and others. In fact, in worrying about the government taking over, the fact that corporate has taken over instead is driving more and more physicians to understand that this is really the way to go, with government-assured national health insurance support going from 42% to 56%. Merritt Hawkins is a firm that does job placements and stuff like that. So they're interested in knowing the lay of the land. The survey methodology here is not the greatest. An absolutely beautiful methodology from Ackerman and Carroll, using national appropriate database and sampling methods, just a little bit older. Unfortunately, they haven't done a third one. showed that support went from 49% in 2002 to 59% in 2007, and I can only imagine it's continued to go up since then. Obviously, there are differences by specialty in support. There are differences by region in support, urban, rural, east, west, north, south, etc. And those are published in Annals of Internal Medicine. So organized medicine is also changing its views. My own New York State Academy of Pediatrics has endorsed the New York Health Act, as has the New York State Academy of Family Practice. And the reasons, the ones that we just described. So again, preserved earning potential, increased professional autonomy. Every patient has the coverage. It's back to Medicare fee-for-service, without prior authorizations. Let professionals act professionally, increase in career satisfaction, decrease administrative burdens, no more prior authorizations, no need to limit fees in order to be eligible for narrow networks. Every doctor takes it, every patient who shows up just has it, uniform comprehensive benefits. So what about the hospitals? During the last Democratic Party primaries for president, 2 candidates supported versions of single payer, the rest did not. And the hospital associations actively lobbied against it with advertising. We would argue that was misunderstood, misapplied on their parts, just as opposition, let's say from the AMA, which is about 50-50 now, and that's AMA members, voting members, which is about 20% of physicians. So let's look at hospitals, how hospitals fare. So their fear was, they're going to go out of business if we do single payer. Well, let's look again at all those other countries. Lo and behold, other rich capitalist democracies have hospitals. This is the hospital beds per 1,000 population. And again, the United States is towards the bottom compared to the OECD average of 4.6. U.S. hospitals are staffed differently, not surprisingly, compared to the U.S. The U.S. has far more administrative, 9.9 per 1,000. So in 9.9 hospital employees employed in administration per 1,000 population, compared to 11.2 clinicians. You see the other countries have more in healthcare clinicians and less in healthcare administrators. So the reality is it's the current financing system that's failing hospitals. If you read any of the literature, you know that the number of hospital beds has decreased. There's hospital closures. Hospitals that don't fully close are reducing what services they provide. And there is an argument going back to, say, when I was in medical school to now, that in fact, we are reducing length of stay for good reasons in how we do care. And we are doing more outpatient. And all of that suggests that, yeah, we could rationally reduce the total number of beds. But the reality is that where those beds, in fact, are being reduced and downsized is disproportionately in poor urban areas and in rural areas. And rich urban and suburban areas get more. And the strongest predictor of hospital closure is serving a high percentage of persons of color. Many studies show an increase in travel or wait time results in worsening outcomes. And frankly, as bad as it has been, let's say in New York City and say Brooklyn and Queens and the outer boroughs with closures, it's even worse in rural America. And so between 2013 and 2020, hospitals have closed so much in rural America, 180, since that the average travel distance has increased from 3.4 miles to 23.9 miles. For persons living in rural America, the travel time to get to a hospital. And as you can imagine, more travel time, worse outcomes. Not a good place to have a heart attack. Much better if you're 3.4 miles away than 24 miles away. In New York State, the numbers went down. In New York City, the numbers went down, and they closed disproportionately in the poorer neighborhoods. Midtown, East Side of Manhattan, not so many closures. These numbers were particularly stark during COVID. We saw, for example, in Queens, 1.5 beds per 1,000 population in Queens, compared to Manhattan has on average 6.4 per 1,000. So some might even call this a form of apartheid. It is certainly a disparity where you have far more beds per 1,000 population in Manhattan than in Queens. just by way of example. It's true for the other boroughs as well. We talk about structural racism in sort of an abstract historical term. This you might refer to, ironically, with sad humor, as structural racism literally. The value of new purchases and total assets of U.S. acute care hospitals. New purchases higher in mainly white serving hospitals compared to Latinx and black serving hospitals. Total assets, accumulated total assets, more in the mainly white serving hospitals than Latinx and black serving hospitals. So literally structural racism. So one of the arguments that the hospital associations are making, despite what I've already presented, is, well, Medicare pays less per person, per event, per treatment. Medicare as is pays less on average than private insurance. And so if we go to all Medicare instead of private insurance, then we will get less money, which will lower our revenues and exacerbate hospital closures. Now, that simplistic argument seems to make sense superficially, but there's some false assumptions based into each of those. So let's talk about that payer mix. So they're assuming that the payer mix is only private insurance and Medicare. Now, that may be true for rich hospitals, but the reality for hospitals overall is that the case mix is including Medicare, private insurance, some, also Medicaid, which pays less, also uninsured, underinsured, and outright charity care. So those that are taking their fair share of the entire population are doing worse. And those few rich hospitals that only take private insurance and Medicare may be doing a little bit better. So the case mix argument is deliberately incomplete on their part. 1. 2, the rates. Medicare as is, they're assuming, has one rate, and they're using the lowest of those rates, and that would be applied everywhere. Well, that's false. So in fact, already Medicare has different rates for different situations. Teaching hospitals get reimbursed at a higher rate. Very, very rural hospitals, very small rural hospitals get a higher rate. Also, single payer models are not based on Medicare as is. They're based roughly on 110% of current Medicare fee-for-service rates. And by the way, in fact, hospitals getting Medicare fee-for-service is at 8% above expenses. So hospitals, in fact, already on just Medicare fee-for-service at current rates are coming out ahead plus 8%. They may be doing even more on some private insurance, and that's why they can afford the fancy schmancy new wing for care that isn't necessarily needed in Midtown East Side Manhattan, while they're still closing elsewhere in the city. So in fact, they're not losing on Medicare, and that's the official government numbers. Maryland hospitals for years have had a requirement that hospitals are all paid the same at the Medicare rates. So the private insurance companies for a hospital in Maryland, you may have heard of Johns Hopkins, for hospitals in Maryland are all paying the Medicare rate by law. And to the extent that single payer is also including global budgeting and not just paying hospitals by fee for service, then the entire question is moot. At the end of the day, you've got transparent, accountable funding based on community need and income with single payer, not some hidden black box negotiated rates between a bunch of different private insurers and a bunch of different hospitals. Then there's the issue of net revenue. Single payer reduces the overhead costs for the hospitals. So not only is it 110% of fee-for-service reimbursement, they're also saving money with single payer because their costs in terms of billing and administrative, as we've seen, are reduced. Their costs for drugs are now down because we've negotiated the prices for drugs, supplies, and other equipment. And remember, hospitals are also employers. And they are currently employers that are generally paying too much for their own employees' health coverage. And so again, as employers, they would save money. And again, the estimates are in the range of 10 to 25% reduction in expenses. So between higher reimbursement rate than current Medicare and reduced expenses, in fact, it's better for hospitals. I'm not just saying this. It turns out that the same three anti-single payer groups far right, and center left, all agree that in fact, under single payer, more payments would go to hospitals than under the current system. So, given this data and this information, that lobbying by the United Hospital Association is simply false. So it's the current system with perverse financing, where their financing is not related to community-wide need, but it's which are the more profitable procedures, which gives us a preferential case mix. How can we game upcoding to gain for optimized billing? And they're incentivized to, do less of less profitable patients. And that's why we have the problems. In fact, hospitals complain all the time that the insurance companies are messing with them in terms of prior authorizations, denying payments, delaying payments, reducing payments. The Greater New York Hospital Association actually ran an ad to the New York State Legislature saying that Medicare, fee-for-service Medicare was the best, and the Medicare Advantage and private insurers were the worst, and they needed to rein in the private insurance companies. They actually ran deny, delay, reduce prior authorization as their slogan. And lo and behold, they still oppose single payer. I don't know why. I have some thoughts. Global budgeting. So the idea is you actually engage in some prospective planning. You know how many people live in a community. You know on average what the healthcare demand and healthcare needs are of that community. And you just assure up front that there's enough funding, capital funding, to have the hospital of the right size, the ambulatory care and specialty units of the right size in a given community. And by the way, not only does that exist in all of those other rich capitalist democracies around the world, it actually exists in varying degrees in other states, including Maryland, Massachusetts, and Pennsylvania. In the case of Pennsylvania, they started doing it during COVID because they were having their own crisis, and that was with a Republican. So again, and when it really comes down to it, there's this whole question of, well, can the system absorb this increased coverage? We're going to offer coverage to everybody. Isn't there suddenly going to be a massive increase in demand? Well, let's think about that for a moment. Let's say we have single payer tomorrow. Today, we have the same number of healthcare need, the same number of patients in principle there's a certain amount of healthcare need out there, and there's a certain amount of doctors in hospitals today. Tomorrow, we have single payer overnight, and then the day after that, there's the same amount of illness in the community, the same number of doctors. Nothing has changed, except that those that actually needed care but couldn't get it before now have access to care. And in fact, we have seen when other countries have flipped from what they had before to universal coverage, or 2 times the United States when we increased coverage. When in the mid-60s, we went from not having Medicare to Medicaid to bringing in Medicare and Medicaid. And then again, under President Obama, when we brought in ACA, it works out in terms of the supply and demand. And again, references at the bottom. But again, the argument doesn't even make sense because the demand was there all the time. It was just unmet need based on ability to pay. So again, I would suggest that single payer is better for hospitals and patients for the reasons already explained. So, we're running out of time here. So what about displaced workers? A lot of those administrative savings are insurance company employees or hospital billing clerks that we're going to displace. Well, all single payer bills, we're progressives, all single payer bills have what's called a just transition. We're actually paying these folks directly, not just promises of, job training, but actual jobs. A lot of these folks actually are clinicians who've taken the higher salary, if you're a nurse or a social worker, to go work for the insurance company and deny care instead of using their clinical skills for good. We should also bear in mind that single payer displaces between 1.8 and 2 million workers nationwide. That's 3% of the annual total year in, year out. The U.S. economy has over 60 million job separations each year, with over 20 million of those being layoffs, being fired, not just, quitting. So again, A, just transition, B, a small one-time event in the great pool of job turnover. Well, I like my Medicare as is. I'm over 65. I like my Medicare. Don't mess with it. Well, the problem with current Medicare is you actually have a lot of out-of-pocket expenses. There's the Part B premium, there's various copays and deductibles for drugs, or you have to do the Part D, which also has a premium, etc. So adding it all up, the average Medicare recipient over 65, not talking about Medicare disability, is paying $6,100. That goes away with single payer. So again, expanded and improved Medicare. It's as if everybody has not just Medicare, but a Medigap coverage, plus drug coverage, dental coverage, and long-term care coverage. So I don't trust the government. I don't want a government takeover. Well, bottom line is you got a choice. What we've currently had is a takeover by Wall Street and private investors for what we might call the commercial determinants of health. So your choice basically is either it's going to be government, which at least has some degree of transparency and public accountability, or it's Wall Street, whose inherent incentive and requirement is just to make money. So what about the alternatives? Republican alternatives basically are let's have health savings accounts. That amounts to an insurance pool of one. Works as long as you're not sick, it works. But if you're sick, it works only if you're a billionaire. Low-cost premium plans. Well, if you expand the low-cost premium plans, what you're getting is higher deductibles, higher copays, narrow networks, and there may be a cap on the total that it pays. The flip side of a deductible. So basically, they're expensive. They're less expensive until you get sick and actually need healthcare, and then they're more expensive. The more conservative wing of the Democratic Party is calling for expanding piecemeal what we've got. The problem there is you don't get the savings, and you still wind up with the whole underinsured problem. Now, some arguments against single payer that I think have some potential validity. One is it'll never happen, right? That our political system is so corrupt that even though it's good for 95% of people, and even though it's good for all the businesses except the health insurers we put out of business, and pharma that just gets to the same lower cost, it'll just never happen in the United States because we're just too corrupt. Or we're so corrupt that even if it passes, so-called regulatory capture will ruin it. The same lobbying will mess it up, how the government runs it. So I'd say, well, Medicare as is actually one of the better run things we've got. And if everybody, rich and medium and poor, are in the system, there's a great incentive by the politicians to do it well. And at the end of the day, I advocate for what's actually best, not what's going to happen anyway. Now, one of the problems with public option that you hear a lot about is you basically do increase coverage a little bit, not 100%, but you don't get the savings. And so you're putting more public money, more taxpayer money in, more of it going to the private insurance companies, and more of it, in fact, going to waste. And you're still not covering everybody, and you're still leaving in medical bankruptcy. This shows the problem about regressive versus progressive funding. So under the status quo system shown in green, what you see here is the lowest income people are paying the highest percentage of their income for health care. That's the 8.4, 9.1% on the left, and in the highest income groups going down to 2.6% of their income on health care. Public option shifts the curve down, but it doesn't change the shape of it. Single payer, as we said before, replacing premiums and out-of-pocket costs, which are at best a flat tax and a regressive tax to the extent that lower income people have more disease, that lower income people would pay a lower percentage of their income, 1.6 or 2.2%, and higher income people with more disposable income pay a higher percentage, 4.5 or 5.5%. So again, back to that slide. You got a plan that's universal, simple, and affordable? I do. So if you're interested in this stuff, you can look